Today we will be learning about the abnormal constituents. We know the normal ones, what are there in urine. Today we will be learning abnormal constituents, and among all those abnormal constituents, the first one is the reducing sugar that you have to know. Fine. So I will be discussing about reducing sugar, and in subsequent classes will be discussed for the proteins, ketone bodies, and bile salts, bile pigments, blood, etc. Whatever the abnormal constituents are present over there. Okay. Okay, here comes the introduction. Fine. Many pathological constituents occur in traces in normal urine and escape the detection due to low sensitivity. In my last class, I told you people what is sensitivity. Anybody remembers what is sensitivity? Okay. So what the sensitivity means, it tests being able to identify the disease. If you are doing a test and the test is giving some result, and depending upon that you come to the conclusion. Now if the test is sensitive, means you can come to the proper diagnosis. Let's say you have done a Benedict test for the reducing sugar. Now the sample is showing that the test is positive. Okay, so you say that yeah, there is reducing sugar present. But if the test is showing negative, does it mean the sample does not have reducing sugar? No, there can be trace, little bit of reducing sugar is there, which is not sufficient enough to give the test positive result. That is what means the low sensitivity. Fine. Now there is one more term, the terminologist. Just get acquainted with the terminologist first. That is the sensitivity. Now comes the specificity. When you will be learning ketone bodies, test for ketone bodies, there is a test called Rothera's test. When you will be doing the Rothera's test, the test might show positive. If the test is showing positive, that means the sample contains ketone bodies. So that is very specific. The test is specific for ketone bodies. If the test is coming positive, means there is ketone bodies. If the Benedict test is coming positive, there could be some other reason as well. Not always because of reducing sugar. There are some other substance in the urine that can also give positive result. So this is not specific. The specific one is the example of Rothera's test. Okay, that is the meaning of the low sensitivity. So you people might be thinking like, why it is low sensitivity? What is the meaning of it? Why low sensitivity? That is the meaning of low sensitivity, that the test is telling you that the sample is having reducing sugar, but it doesn't mean that if the test is coming negative, it doesn't have reducing sugar. It can have, but the amount is so less that the test is coming negative. Fine. Okay. Now their concentrations are increased. Their concentrations are increased markedly in the urine in different pathological conditions. Fine. The reducing sugar can be increased in different conditions, or the other abnormal constituents that can be increased in urine in pathological conditions, not in the physiological. What is physiological and what is pathological? Pathological means that is causing us the disease, and physiological means it is normally the normal physiology, because of that only the reducing sugar is coming. Okay, if it is physiological, the test will not come positive, but if it is pathological, definitely the test will come positive. Fine. Now on standing, urine undergoes bacterial fermentation. What does it mean? When you are taking a urine sample and keeping it over there for 24 hours, let's say, there will be some organism that will be growing in the sample. That is the fermentation happening, and the organisms are going in the sample. Fine. Now, it can be preserved under refrigeration or by adding chemicals like toluene and chloroform. These are the two chemicals that we are using to preserve a urine sample. Let's say you take a urine sample from a patient and you have to send the urine sample far away from here. You don't have a lab over here, you have to send the sample to somewhere else. So you cannot send it right now. You have to send it after some time. Somebody will come, the transporter will come, and then they will send. Till then, how will you keep it? If you keep the urine sample just like that, there will be growth of organism. Then later on they will do the test and they will be finding microorganisms in the sample, and they will be giving the interpretation that the patient is having some infection, organisms are there, but which is a false result. So because of that, you have to preserve the urine sample as it is, so that the other organism doesn't grow in the sample. Fine. So for that reason, we have to use the toluene or chloroform. Okay. Now when we are taking the urine sample, how it have to be taken first, that is also important. Like a patient is coming, you are suspecting some disease in the patient, and you are telling the patient to go for the routine urine checkup. And how the patient will give the urine sample, what we should generally do, that is the gold standard, is you have to tell the patient to urinate from 8 AM today morning to 8 AM tomorrow morning. So you have to collect the whole 24-hour urine sample, and then you have to do the test from there. But is it practically possible that somebody is going to the lab and waiting for 24 hours? Not possible, right? So that is why we take the early morning fresh voided urine sample. Fine. That is what the urine sample we are taking. And these are the physical characteristics in pathological conditions. You already know the physical characteristics in normal urine. Fine. Somebody stand up and tell, in normal urine what is the color? Pale yellow. What is the reason of pale yellow? Urochrome or urobilin. Yes. Because of that, the color is yellow. Now, what is the appearance of normal urine? Appearance? Clear. Basically, it is clear. But when it is pathological, it becomes turbid or opalescent. Turbid means, in Bengali we say ghola, and in English, ghola. You should get acquainted with Bengalis as well as in English as well. So the patient will come and say like, my urine is becoming ghola. It is not clear. It is something is there. Some whitish particles are there. They cannot say in English to you. So that's why you have to acquainted with the Bengalis as well. I'm just making it easier for you. If you have any difficulties, you can ask anytime. And then odor. What is the odor? That is the smell. Normal urine smell, aromatic. Okay, normal urine smell is aromatic, but it becomes ammoniacal when? If you preserve it for a long time. The ammonia, the urea that is present in the urine, that will give the ammoniacal smell, or only if you keep it for a longer period of duration. But the freshly passed urine don't smell. That is why in the urinals, if you see, when you are passing urine, you won't get the smell. But somebody has passed 1 or 2 hours back, then you are going and they did not flush it properly, you will get the smell. That is what the ammonia smell on prolonged. Okay, and there are some disease condition where also you can get the odor which is abnormal, like in case of DK, diabetic ketoacidosis, where we were doing the Rotheras test for ketone body estimation. If there is ketone bodies present in the urine will smell sweet. Okay, the ketone bodies, there are 3 examples of ketone bodies: acetone, acetoacetate and beta hydroxybutyrate. Now beta hydroxybutyrate don't show the test, but acetone and acetoacetate gives the test positive. That you will get to know later on when we will do the Rotheras test. Fine. For now, just remember that the ketone bodies gives a sweet smell. Okay. And there is another condition, that is MSUD. Ma'am has told you people MSUD, if you recall in her slides. Anybody? Maple syrup urine disease, right? In maple syrup urine disease, you will get the smell of a burnt sugar. Fine. And there is one more condition when you can get a mousy smell. I have not written it over here. Anybody has any idea that in which condition you can get a mousy smell? You ever heard about phenylketonuria? PKU in short we terminate. Okay. In that case, you can get a mousy smell. Fine. And then comes the volume. Now urine output is increased in conditions like diabetes or effect of drugs. Now you know already from your previous classes what is polyuria, oliguria and anuria. What is polyuria? ml over per day over 24 hours. If it is more than 2500 ml, that is polyuria. What is oliguria?
500
less than 500 ml, that is oliguria. And what is anuria? Less than 100. Complete cessation of urine. So there is less urine production, that is why anuria is occurring. Okay. So these are the causes of polyuria. What are the causes? Like diabetes. The diabetes can be diabetes insipidus or it could be diabetes mellitus. In both the conditions, the polyuria will be there, but the reasons are different. In case of diabetes insipidus, the volume is more. Okay, that's why polyuria is happening. But in case of diabetes mellitus, can anybody tell me why in case of diabetes mellitus there will be polyuria? Why? Because when in diabetes mellitus, the reducing sugar is coming out. Whenever the reducing sugar is coming out in the urine, it is taking water along with it. So that's why the patient feels like passing urine again and again. That is the urge to pass urine. That is why they will develop the polyuria. But in case of diabetes insipidus, it is completely separate reason. It's because of the antidiuretic hormone that is releasing from our pituitary. That you will get to know later on. Okay. So because of antidiuretic hormones, the diabetes insipidus is taking place where the volume is more. So the urine volume is more and the patient is passing urine again and again. Fine. Now, there are some conditions where the urine output is also decreasing. Which are the conditions? That is, one is like nephritis. What is nephritis? Can anybody tell? Just break the words, you will get the answer. Exactly. Itis means inflammation and nephro means kidney. So, kidney inflammation, any kidney pathologies, it can be acute, it can be chronic. Acute means less than 3 to 6 months. Within that period, patient is developing some kidney symptoms. That is acute. Chronic means patient is chronically having. Prolonged. The GFR, that is the glomerular filtration rate that you will learn in physiology. The GFR is decreasing over the time. Because of that, the patient is getting chronic kidney disease. So, in those conditions also, you will get oliguria. Now, there is one condition that there are some conditions where there is total suppression, that is anuria. Anuria, complete cessation of urine output. Which are those conditions? Like, one is shock. Anybody has any idea about shock? What is shock? Not the electric shock. So, for you people, the basic idea that you should have. Shock is, anybody have acquainted with the blood pressure? You know blood pressure, right? How to measure? We will learn in physio. But blood pressure, a patient is coming whose blood pressure is very low. Patient is having tachycardia, means heart rate is very high, and patient's general condition, that the we say the GCS score or the consciousness, the patient is either unconscious or comatose or semi-conscious or can be completely unconscious only. Okay, so depending upon that we say that the patient is having shock or not. It can be because of infection, that is known as septic shock. It can be neurogenic. It can be, there are many other reasons like anaphylactic shock. You gave some patient an blood transfusion and the patient immediately developed shock. Why? Exactly, antigen antibody reaction. That is also written over here. See, incompatible blood transfusion. So because of all these reasons, the patient can develop shock. The blood transfusion one is an anaphylactic shock because of the cross matching was not done properly. That is why the patient developed anaphylactic shock. Septic shock, patient is getting infection. And because of infection, the organism are growing. You are giving antibiotics. Antibiotics are not working. The infection is spreading in multiple organs. The organs are shutting down. Fine. The same infection is hampering the kidney as well. The kidney is not working properly. Urine output is not happening. That is why complete anuria can occur. Anybody has any difficulties in understanding? Please raise your hands if you have any queries. And there are some poisoning as well, like for example mercury poisoning. Okay, so acute nephritis. If it is an acute onset of kidney disease, let's say patient was normal, completely fine till yesterday. From today onwards, patient is having let's say some trauma. Patient has an RTA, road traffic accident, and after that the kidney got injured, and because of that injury the kidney stopped functioning, and patient also got infection as well. Okay, nephritis means inflammation. It can be because of infection, it can be because of any other reason, and because of that now the patient is not passing urine completely. So the kidney has gone completely shut down. It can be because of any pathologies. It can be, there are multiple pathologies that can be possible. So in general, when the kidney stops functioning all of a sudden, the patient will experience like there is no urine coming out because the kidney is not filtering. Okay, fine. Now the color. Urine becomes smoky brown in presence of blood. If the blood is there, hematuria. If the blood is there, it will become smoky brown. If there is bilirubin, can anybody tell me when there can be bilirubin in urine? Jaundice. In case of liver pathologies, if the patient is having some liver pathologies, the bilirubin is high in the body, urochrome is too much in the body, and that urochrome is converting into bilirubin and ultimately coming out in urine, and that is giving the dark yellow color, not the pale yellow color as normal. Fine. And then black color when melanin is present. Now anybody has any idea what is melanin? The skin pigmentation, the skin color that comes, that is because of melanin. Okay. Now there are some conditions, it can be cancer, and there are some conditions in which the melanin content is high. It's so high that it is getting excreted in the urine as well, and that is what can give you a black color of urine. There is one more condition when the urine can be black. The next point which is written, the condition is alkaptonuria. What happens is the patient will come with a particular complaint that my urine was fine when I was voiding, but as soon as I finished voiding, I saw that the urine turned black. Just like a magic. If you keep the urine, please take the urine in a beaker, keep it for some time, it will turn black. Fine. This is a specific case that can happen in case of alkaptonuria. Now why it happens? That is a question that can be asked to your vivas. Okay. That reason is homogenesic acid. HGA, homogenesic acid, that causes this black coloration on prolonged standing. Understood? And urine becomes milky if pus, bacteria, epithelial cell and lipids are present. These are very basic things, like if there is any infective organism, pus is there or some bacteria are there, you can see some dense thick products which is there in the urine. You will not be understanding like what is it, but it will be some little bit whitish. And when can be milk present in urine? Anybody has any idea? Yes. And some close? When can be milk in urine? Infants who is on breastfeed, they can show. The milk is like Lactosuria. The lactose that is there high in concentration in breast milk. Whenever the baby is on breast milk or the mother who is breastfeeding, they have lactose in high concentration in their body. So that can come out in their urine, which is not a disease. It's not a disease, it's a physiological condition, because the lactose is so much in your body that is, it is the extra amount is coming out in your urine. Fine. Now pH, urine is significantly acidic in fever and decay like diabetic ketoacidosis. These are some conditions when the pH can be low. Normally the pH of urine is 5 to 6, average is 5 to 6, but in this condition it can go below that as well. Okay. And specific gravity, it is increased in acute nephritis and decreased in diabetes insipidus. Someone tell me why is it increased in acute nephritis and decreased in diabetes insipidus? What do you understand by specific gravity? If I ask you to tell me what is specific gravity in your own language, what is specific gravity? Not the bookish definition.
If the concentration is more, that means specific gravity is less.
Concentration of what? Solutes, yes. If the solutes are more, the specific gravity will be more. If the solutes are less, then the specific gravity will be less. Okay? Now, there are the list of the abnormal constituents that you can find in a urine sample. What are the abnormal constituents? First of all, that I will be discussing is the reducing sugar. Okay? There are some more as well, like protein, Baines-Jones protein. Now, Baines-Jones protein is an exception. It's a specific protein that can be found in one clinical condition specifically, that is multiple myeloma. This can be asked in your viva if you are doing too good in your viva for an honors question. If you can answer this, they will give you more than 70% marks. Like that kind of question, this topic is. Why Baines-Jones proteins? You will not do it in your regular classes. You will not do the test for Baines-Jones proteins. But you have to know it because they can ask question from it. Fine? Now the blood can be there, ketone bodies can be there, and bile salts and bile pigments can be there. Now there are some conditions when we are doing this test. Why we should do the urine test? What is the need of doing urine test? We can do blood test as well, we can do other tests as well. Why to do the urine test? These are some conditions where we require the urine test, like diabetes mellitus, some liver disease, whether the liver disease, the patient is having liver disease and bile salts and bile pigments are coming in the urine. Renal disease, if the renal glycosuria is happening. I'll explain what is renal glycosuria. The renal glycosuria is when you are having normal blood sugar level in your body. But if you check in the urine sample, the reducing sugar is present. How come is it possible? In your body, the glucose is normal. In your body, the reducing sugar is normal when you are doing the blood test. But when you are checking the urine sample, the reducing sugar is more. How come is it possible? Anybody has any idea? How come is it possible? See, the body, the reducing sugar that is present in our body, that is normal. But when it is getting excreted through the kidney is not being able to reabsorb it. Kidney should reabsorb it. That is its function. Now it is not being able to reabsorb it and the sugar is coming out as it is in the urine. So that is the pathology in the kidney, not in the body. So you will get the reducing sugar high in the patient, but that you may come to the inference like the patient is having diabetes mellitus. Sugar is high, patient is having diabetes mellitus, but no. It could be because of kidney pathology as well. That's why whenever you are getting this, you have to correlate with the blood sugar. Fine? The urine reducing sugar, you have to correlate with the blood sugar. And sometimes, let's say the urinary reducing sugar is high. You got the test positive. And blood sugar is also normal. And you have tested for the kidneys as well. The kidneys are also showing normal. But still the reducing sugar is coming in the urine. When is it possible? You have to ask the patient about his or her diet. Probably the patient took 100 chocolates that day morning only. What if you don't know? Patient might take. So because of that, because of increased consumption of the glucose in the body is so high that the unwanted glucose is getting excreted in the urine. So that's not a disease again, that's a physiology which is depending upon the diet of the patient. So whenever you are coming to a conclusion, you have to ask about the history first, which you will learn in your second year onwards. How to ask the history first. You have to always take the history properly. Don't come to the conclusion immediately after you see the report. Urinary glucose is present doesn't mean that it is diabetes mellitus. It could be multiple other reasons. These are some examples to make you understand how these cases can come. These are some clinical correlation, clinical importance to it. Fine. Now these are the tests like urine pH we check, specific gravity we check, blood we check, proteins, glucose, ketone bodies and WBC count, white blood cells. Can anybody tell me why we see for WBCs in urine sample? Not infected tissues per se, these are the dead WBCs. whenever our body is getting any infection, what is our guard? Like the soldiers we have in our border, what are the soldiers in our body? WBCs, right? So WBCs come to fight over there. Once they fight, the organism dies, WBC also dies. And when the WBCs are dying more in number, they will form the pus. That is why whenever a patient comes and says that some pus is coming out from there, in Bengali, pooch, some pooch is coming from there. Okay, that means that infection is increasing. More and more WBCs are getting killed. So you have to give more powerful antibiotic to that patient. If the patient is already taking oral, you have to give IV antibiotics. If the patient is not on antibiotics, you have to give them antibiotic coverage so that the infection get controlled, so that the organism dies, not your WBCs. Get it? So that's why we check the WBCs as well. In urinary tract, if there is any urinary tract infection, the WBC count can be high, the pus can be there. That is why we check for all these things. Fine? Next. Now this is my subject. Test for reducing sugar. What we will be doing? The Benedict test. Very simple test. Those who have already attended, they know the test is very simple, easy to do. But the things that you have to know is the principle of the test, the reagent, that the constituents of the reagents, and what is the reaction that is happening in the test. Fine? I'll explain you. But these slides, these photos are just so you get some idea what are the next topics will be and how will it look. Like over here, see, the test for reducing sugar is Benedict test. I'll be discussing only this much. Fine. The next topic will be of test for proteins, which will be in the subsequent classes. We'll be doing heat coagulation test in your lab. But the rest of the two things that can be asked in your viva. Like what is sulfosalicylic acid test is used for? To identify what? Protein. Hellus nitric acid test for what? For protein, for diagnosing protein. So these kind of questions can be asked. Don't just depend on only one test like, yeah, we have done heat coagulation test in lab, so rest of the two are not necessary. You have to know the names and for what purpose we are doing it. Fine? So this is a picture of heat coagulation test. Whenever you are taking the urine sample and you are just hitting the upper portion of the urine, and it will give a white coagulum. Okay, this is the white coagulum that we know from our 12th. Like whenever you heat protein, it denaturates and forms a white coagulum. The same thing happens over here, the same principle, depending on the same principle. If there is protein in the urine sample, as soon as you heat it, the protein breaks down and it forms the coagulum. That is the heat coagulation test. Fine. Now the Benz-Jones proteins. This is only for just so you know and see once how it looks. Benz-Jones proteins, two tests we do. That is, one is flocculation test, another one is Osgood-Haskins test. Done for multiple myeloma. Again and again saying multiple myeloma. These questions are being asked in the NEET PG examination, which you are ultimately preparing for. Once you finish your course, your target should be that. So these kind of questions are asked in those exams, competitive exams. There will be multiple options, and some questions will be that the patient came with so and so complaints, so and so CT findings, and ultimately there is one keyword, the patient's urine sample showed Benz-Jones proteins. What can be the diagnosis? Fine. So that is multiple myeloma for you. So you have to know that part. And there are tests for blood, that is a benzidine test, that will get covered. Tests for ketone bodies, there is two tests, Rotheras test and Gerhardt test. We will be doing only Rotheras test in the lab. This is the Rotheras test. This is the pink, purple color ring that will appear in the test tube that ma'am will take class and you will get to know later on. Test for bile salts, Hayes sulfur test. Similarly, test for bile pigments, there is Faucher test, Gellin test, and the Ehrlich test. These are the photos so that you have an idea, because we are not going to do this in our labs. So these are the photos so that you have how it looks at least. Because see, if you see something, you will remember that. If I just give you a lecture of like test for bile pigment, these are the three names, you might remember, you might not remember. But when you are seeing and you are recalling the names along with it, it will help you a little bit more to remember this. Fine? Now, this is a funny slide. Rather be sick than basic. Why? Why this slide is here? Pardon? Huh? Another reason? There is one keyword in this slide. I did not put this slide just for any reason. There is a reason. Can anybody find? Those people who have already attended my last class, they will get to know that why is it basic. Why is it basic? Why basic is important? For Benedict test, the medium should be what? Alkaline. Alkaline. That is basic. Fine. Yeah. Okay, so this is Benedict's qualitative test for the reducing sugars. This is how the Benedict sample looks like. Okay, and this is how we were going to do the test. Those people who are new, this is how we will go do the test, and those who have already done, they have an upper hand. You will be cooperating with the new people, let them do the test as well. You will also do, but let them do first, then you people do. Fine? Next. The principle. What is the principle of the test? In a hot alkaline medium. See, the first word is alkaline. The medium have to be hot, the medium have to be alkaline. Other than these two things, the test is not going to take place. If you just mix the sample in hot alkaline medium, reducing sugar gives enediol. I have already discussed in my last class that enediol is a strong reducing agent which causes what? Reduces the cupric ions into cuprous ions. Now those new people, they will be thinking like, from where cupric ion is coming, from where it is getting converted into cuprous ions, then to copper hydroxide and then converted to cuprous oxide. What is this? I'll get into it. The reaction which is taking place is in the medium, when the medium is hot and alkaline. The alkaline medium, it gives enediol. Enediol is the one that is reducing the copper sulfate. The copper sulfate is one of the product in the reagent that is there. It is breaking the copper sulfate is breaking into copper and sulfate. That is the source of the cupric ion. Now the cupric ions get converted into cuprous ion. Fine? The cuprous ion reacts with the water, forms cuprous hydroxide. Later on, ultimately it gets converted into cuprous oxide. And this cuprous oxide is the byproduct that is giving the red color precipitate. Fine? Are people understanding? Okay. In Benedict's qualitative test, the blue color changes into different colors depending upon the concentration of the reducing agents. So what does this line means? Like I have shown you in the last slide that the color of the sample is blue. Okay. Now when you take the sample and mix it with the urine sample that you are getting and you are heating it, the color that is there in the blue, it should change into multiple colors. The multiple colors could be, it could be green, it could be yellow, it could be orange to red, or it could be brick red. It depends how much reducing sugar it is there in the sample. Depending upon that, the color will also be different. Understanding? So that is how the test reacts. And this test helps in distinguishing between the reducing and the non-reducing sugar. There are two types of sugars you already know. Some are reducing, some are non-reducing. And some other classification also there like monosaccharide, oligosaccharide, polysaccharide. This has already been covered in your theory classes. So mainly the Benedict test is positive for monosaccharides and reducing sugars. And non-reducing sugars don't give this test positive, but there are some exceptions that you will get to know later. Okay, some exceptions are there which are non-reducing sugar but still gives a positive test. Fine, so I'll talk about that later on. Now where I was is, this is the byproduct that is giving you the red precipitate. So examiner might ask you why this red precipitate is there. What is the product that is giving you the red color? That is the cuprous oxide. Okay, and the two important thing is the hot and the alkaline medium, and the strong reducing agent is the enediol. Okay, now here is one word written, that Benedict's qualitative test. Anybody remembers what is qualitative and what is quantitative? I have already explained last class. What is qualitative? What is quantitative? And because the change in color, you are close but you did not say the exact word. There is one word that is missing from there. Like let's say we are doing a blood test. We can get the exact value of blood sugar from there. But urine test we cannot get the exact value. We will get an approximation. If the color is changing, we will get an approximation that how much blood sugar, reducing sugar can be there. Not the exact amount of reducing sugar that is there. We cannot estimate that from the urine test. So that is why it's a qualitative test. It will tell you the quality of the urine sample, whether it contains the reducing sugar or not. It will not give you the quantity of the reducing sugar. So quality means it is giving you the quality, whether it's present or not. And quantitative means it giving you the exact value of the reducing sugar that is present. Fine. Now the composition. These are the compositions of the Benedict's qualitative reagent. What are the composition? First is the copper sulfate. Now those who were thinking like from where the cupric ions are coming, this is the copper sulfate which breaks down and gives you the cupric ion in the solution. Got your answer? Now sodium carbonate is the one that is making the medium alkaline. Other than this, the test will not take place. And the sodium citrate. Now why sodium citrate is so important in this test? Alkaline medium this is giving, cupric ion this is giving. Now why sodium citrate? The sodium citrate is important because the copper sulfate which is giving the cupric ions, if you don't give sodium citrate, these cupric ions will immediately get reduced. immediately the reaction will take place and the reaction will not happen. So we need a steady continuous supply of cupric ion in the reaction, so that the test takes little bit more time. All the substances, all the cupric ions in the sample gets reduced and then converts into the cuprous oxide. So because of that we are giving sodium citrate. Now this sodium citrate is doing what? It is binding with the cupric ions, and it is binding with a loose bond, not a solid bond, like it made a solid bond and later on it is not denaturating only. It has made a solid bond. So it will make a loose bond, and after that what will happen? Eventually when the medium is hot, it will slowly take place and it will slowly denaturate, and ultimately it will break down and it will give a steady continuous supply of cupric ion to the supply, to the reaction, and ultimately the test will take place. So that is what is the importance of the sodium citrate. When it prevents the precipitation of the cupric ions immediately and forms a loosely bound complex with the cupric ions and forms the sodium citrate cupric complex. This is the complex that it forms. You have to remember this, you have to by heart all these things, can't help it. These are difficult, but you have to remember. So sodium citrate binding with copper's cupric ions, forming a sodium citrate cupric complex, which is a loosely bound complex. Later on it dissociates and gives the continuous supply of the cupric ions to the reaction. Any doubts? Anybody has any doubts? Wow, very good. Nobody has any doubt. Now procedure. What is the procedure? Take 5 ml of Benedict's qualitative reagent in a test tube and add 8 drops of urine and mix it well. Okay? And then boil the solution for 2 to 3 minutes and wait for the color change. See, that's simple. The test is very simple. It's nothing. Just take the Benedict's reagent. How much? 5 ml of it. Add 8 drops of urine sample into it. Mix it very nicely and then keep it boiling for 2 to 3 minutes. After you boil, you can see the color change. You might not see the color change as well. If there is no sugar, there will be no color change. And if the color change is there, depending upon that, you will come to the inference. Once you let it cool down, that is what? A change in the blue to different colors like green, yellow, orange red and brick red is indicative of presence of the reducing sugars in different concentrations. But once you boil, do not come to the conclusion immediately. Once you boil, keep that test tube, let it cool down. Once it cools down, check for the precipitate and then comment. Clear? And there can be one question like why 8 drops of urine is only added. Okay, this is very common question that they ask, commonly asked question. Why 8 drops of urine sample is added in the sample? We could have added 6 drops, we could have added 10 drops. Why not less? Why not more? Why 8 drops only? And that's because I told you before, like there are some other non-reducing sugars as well, non-reducing substance as well, which is giving the test as positive. That is why the test is having low sensitivity. Now you can correlate the thing. The test is having low sensitivity because not only the glucose, not only the reducing sugar, other contents are also there which can give the test positive. Now if you add more than 8 drops, the other products like an example ascorbic acid, glutathione, homogentic acid, these are there, that will give you the test positive. Now the patient is not suffering from diabetes mellitus, patient is not having glycosuria, but still because of these byproducts, when you have added more than 8 drops, probably 10 drops or 12 drops, the test is getting positive. And you will come into the inference like the patient is having glycosuria, कोई diabetes mellitus भी हो सकता है, it can be renal glycosuria as well, it can be whatever the reason, whatever the multiple options of the diseases that can happen where the sugar is present. But the patient is completely normal. Only because of these byproducts the test is coming positive. That is why we don't add more than 8 drops. We always add 8 drops. And somebody asked in my last class, why sir only 5 ml of Benedict's reagent? Why not more than 5 ml? Why not 6 ml? So this is a titration. It is already been tested and titrated just like that. Let's say you take a glass of water and you add 1 pinch of salt in it. Okay, the titration of the salt is, you know, 1 pinch. In another glass you take same amount of water and you add 2 pinch of salt. Which one has more? Which titration is more? The second one, clearly, that is the easy concept. Now compare, you take 5 ml of Benedict's qualitative reagent and add 8 drops in it. And you take 6 ml of Benedict's qualitative reagent and add 6 drops in it. Is it equal? So it will never be equal because these 8 drops will react with 5 ml only. That is how it is titrated. If you remember in your class 12 classes, you have done the KMNO4 titration. Remember that purple color comes, till the purple color comes, you keep on titrating. That is titration. So that is how it has already been titrated. It's a fixed amount that has been titrated and it has been tested like that. So we can't change it like why not 5 ml. During our test we randomly take 5 ml or 6 ml. But in labs when you are practicing or somebody is doing this test, they have to take 5 ml, otherwise they will get the faulty results. Okay? So that is why we don't take more than 5 ml or less than 5 ml. That is why we don't take more than 8 drops or less than 8 drops. Now this is the reaction that is taking place that I was talking to you. The reducing sugar is there reacting with the sodium carbonate. Sodium carbonate is doing what? Sodium carbonate is doing what?
Acting as a reagent.
Say. Sodium carbonate, you. Sodium carbonate is doing what?
As a reagent.
At least stand up, then say the answer. Not you. Behind you.
It's acting as a reagent in the reaction.
What is the function of sodium carbonate? It's a reagent. I know it's a product of the reagent. What is the function of sodium carbonate? No, it's not reducing sodium. Making it alkaline. It is making the medium alkaline. Yeah, sit down. Now there is cupric ions reacting with the NADIOLs, forming cuprous ions, and the cuprous ions are giving the brick-red precipitate that you have already seen in the slide. This is just a reaction that is happening over there. Now these are the interpretation. Now in your test you will not get colors like this. This is just to give you an example. Don't expect the colors will be just like this. Okay. So this is just to give you an example. If the color is blue, means there is no color change. That is, there is no reducing sugar. Okay. Or could be little bit, but it is so less that the test is not taking place on it. Okay. Now green is traceable. That is, it is low but less than low as well. So it's little bit of reducing sugar is there, that is giving the test. So that's why the green color is coming. If the concentration is low, then it will be orange color. Now the percentage which is written over here, this is the percentage of the reducing sugar that is present in the sample, because of which this color will come. Like in case of green, the percentage will be 0.5% to 1%. If it is 1 to 1.5%, it will give yellow color. If it is 1.5 to 2%, it will give orange to red color. If it is more than 2 gram %, then it is brick red color. Fine. These are the color changes that you can see, and these are the concentrations that you can see. Fine. Now some clinical interpretation. Now why we are doing this test? What is the applied importance? Whatever you study, whatever you learn in first year onwards, always try to correlate it clinically. Like, why is it important? What will we do by knowing it? Why we are learning it? That why should always be there in your mind, then only you will understand the subject. Whenever you are studying something, why you are studying it? The clinical interpretation is a very small amount of reducing sugar may be present in urine, and this is insufficient to give the positive result in any common laboratory. That I have already explained, like that amount is so less, it is not giving the test positive. But if the amount is significantly increased, the amounts can be observed in several conditions. What are the conditions now? One is diabetes mellitus. Everybody know what is diabetes mellitus? That is the, in common language we say sugar. I am having sugar, my parents is having sugar, these are all the things, patient is coming with sugar. So the disease terminology is a diabetes mellitus, and the local name that we say is the sugar. Now, lactosuria can be found in urine, that I was saying. Lactosuria can be found in lactating women and neonates, those who are depending upon breastfeed. Neonates are those ones whose age is less than 1 month. Infants are those whose age are less than 1 year. 1 month se niche hua to neonate, 1 year se niche hua to infant. Fine. So those people, those babies, I should say babies, those babies and lactating women, they have lactose in their body in high concentration. Can anybody say why lactose is high? For which hormone? Though it is difficult.
Prolactin.
Yes, prolactin. Very good. Nice. So because of prolactin, the lactose is getting produced. And why the lactose? No, how the milk is getting ejected? It will be taught to you in physiology. Say. Oxytocin. Yes, the oxytocin is helping in ejection and the prolactin is helping in production. So these are the two different hormones helping. Now, in renal glycosuria, where the blood glucose level is normal, but the renal threshold for glucose is lower. I have already explained, the urine sample is showing presence of the reducing sugar, but when you have checked the blood sample, there is no blood sugar. So that means the patient is having some pathology in the kidney, that is a renal glycosuria. The renal threshold for the glucose is lower, means the kidney is not reabsorbing the glucose. That's why the glucose is coming out, the reducing sugar is coming out in urine as it is. So the concentration of the reducing sugar in the body is normal, but in the urine it is high. Understanding? Now galactosuria is a condition which is an inherited disorder. What is inherited disorder? Inherited disorder means by birth. If you are getting the disease from birth, that is an inherited disorder. And what is an acquired disorder? You say, what is inherited disorder? Stand up, yeah. What is inherited disorder?
Inherited disorder.
Yeah. From birth, by birth. What were you doing in the phone? Sit down. Now, galactosuria is one condition that can happen in infants as an inherited disorder. Now, inherited disorder, you understood that it is from birth. Due to the defect of some genetics, the genes which is defective is the GALT gene, G-A-L-T. Okay, the GALT gene is defective in both the parents, father as well as mother. There are some conditions where only one gene is defective and the patient can get the disease. That is a dominant disease. And recessive disease is both the genes have to be defective. Then only the patient will get. So it's a inherited disorder but recessive disease. That's why both the parents, father and mother, as well as both of them should have a defective GALT gene. Now, in this condition, what will happen? There is a galactosuria. Now, if you break the word, you will get galactosuria means coming of galactose in the urine. Why? The galactose is not getting metabolized. The galactose is metabolized by which enzyme? The enzyme is GAL1PUT. Anybody knows the full form? It's GAL-PUT, GAL1-PUT. Okay. The GAL1-PUT means galactose 1-phosphoruridyl transferase. Okay, galactose 1-phosphoruridyl transferase. So that is the enzyme which is defective. Because of that, the galactose is not getting metabolized and it is coming out in the urine as it is in the body. Fine. That is why the galactosuria can also occur. Now some extra ages, as I have already mentioned beforehand, that some non-reducing sugar can also give the test positive. Even though this test should be positive only for reducing sugars, there are some exceptions with the non-reducing sugars that is also giving the test positive. What are those non-reducing sugars? Here are some lists like creatinine, ascorbic acid, urates and glucuronides. You have to by heart these things because these are exceptions. Drugs like salicylates, PAS, that is para-aminosalicylic acid, isoniazid can also give false positive result. Anybody can tell me where isoniazid is used? Now let's say a clinical case given to you. A patient comes with long-standing cough, you are suspecting TB. Now you have started some medicine and because of taking that medicine, the patient is having orange color urine and the glucose content is also high. There are two drugs that is there in TB regime that is widely used. That one is rifampicin, another one is the isoniazid. This isoniazid is responsible for giving false positive result and rifampicin is responsible for giving the orange color of the urine. These two things can be asked as a clinical case. Like in a TB patient, when you are giving the drugs, the routine drugs, there are two more drugs. I am not mentioning that, you will get to know in your pharma. But these two drugs which is coming related to the topic is rifampicin and isoniazid. Rifampicin gives orange color urine specifically and isoniazid gives a false positive result of the Benedict test. Now reducing sugars like sucrose, starch and other polysaccharides gives negative test. Now sucrose should give positive test, right? Why sucrose is not giving positive test? Anybody has any idea? Sucrose is what? Monosaccharide? Is it a monosaccharide? Disaccharide. What are the contents of sucrose? Be loud. Whoever is saying, just stand up and say it loudly. Yes, correct. Glucose and fructose. It's a disaccharide. And what I say, Benedict test is mostly positive for monosaccharides and reducing sugars. So that's why sucrose is not giving the positive test. And starch and polysaccharide, these are already polysaccharide. That's why they don't give positive results. Now, if reducing sugar is detected in the urine, blood sugar level must be correlated. That's the same concept comes as the renal glycosuria. I am telling the same thing again and again so that it gets hammered in your brain. That yeah, I have been listening it again and again, sir has been telling it again and again. So whenever you are getting a urine sample for the reducing sugar, when you are testing it, you should always cross check it with the blood sample to come to the conclusion. Fine. Nowadays, the presence of the glucose in urine can be confirmed by dry chemistry. These are some advanced processes that we are doing nowadays, which won't be doing, you people won't be doing in the lab. These are just for your knowledge. Like glucose stick is one thing that you can take your sample and you can check the urine sample at your home only just with a stick. That is glucose sticks. Okay, like we do in case of ketone bodies as well. There are one strip you put in the urine sample, there are some color changes and there are some markings. Depending upon the color change, you say how much ketone bodies is there, 1 plus, 2 plus, 3 plus. Same way, in case of glucose also, glucose sticks are available with which you can say how much amount of glucose can be there. Just an approximation, not the exact amount. Okay, and there is paper chromatography technique as well, which is performed to identify the specific nature of the sugar. Like let's say you have done a urine sample for the reducing sugar, the test is positive. Now you don't know which type of reducing sugar is there. Is it a glucose, it's a fructose, it's a maltose, you don't know. For that reason you have to do the paper chromatography. You don't have to need to know what is paper chromatography, how to do it, that is PG level. Okay, but you have to just know the name. Like in case you have been asked like how to identify which kind of reducing sugar is it, so that time we do the paper chromatography test. Understandable? Now there are some question and answers. I told you I will ask you questions. So, what are the common causes of oliguria? Yeah, when the urine output is less than 500 ml over 24 hours, that is oliguria. Clear? Understood? What is polyuria? Polyuria? You tell her.
When the urine comes with more than 800 to 2500 ml.
More than 2500 ml, not 800. 800 to
2500 is the
normal value. That is polyuria. Okay, sit down. What is glycosuria? What is glycosuria? Glyco means what? Glucose, sugar. Sugar is present in the urine. That is what is glycosuria. Understood? Sit down. Next. Next. Next to her. Yeah. Stand up. Tell me the common causes of oliguria. Yeah. Stand up. Don't ask him. He won't help you. I can see everything. What are the common causes of oliguria? I have explained in my class only right now, few minutes back. I have explained the causes of oliguria. Where were you people? Just sitting over there won't help you pass the exam. You say? What are the causes of oliguria?
Oliguria, sir.
Stand properly, don't put your hand inside the pocket. Say, what are the common causes of oliguria? When the urine output will be less. Right? 500 से कम आया, यहाँ पे भी गलत है. कौन से कंडीशन में होगा? Which condition? Which are the conditions when there can be oliguria? Everybody is prepared to write down the answers. Right? Everybody is prepared to write down the answer. I'll just say the answers, everybody will write down. Polyuria means what? The urine is more amount of urine is coming out. In dehydration, more amount of urine will come out. The body is already dehydrated. From where the urine will come out? You are saying the example of oliguria. Probably somebody told you the example of oliguria is dehydration. What is glycosuria? Pardon? Sugar content is more. Which condition you can get glycosuria? Next to you. Tell me two conditions where there can be glycosuria. Two conditions where can be glycosuria. Don't have any idea. What were you doing in the class? For the last, how much time? 1 hour almost. You tell me. You tell me, what are the causes of glycosuria? Just now I have told. Say glycosuria. What are the causes of glycosuria? One is renal glycosuria. Right now I said. Another one you say. Iso? Say it. If you are saying something, say it boldly. If it might be wrong, it might be true, doesn't matter. Say it. If you're saying, then say it. Anybody can answer? Reasons for glycosuria? Diabetes mellitus. See, they are answering. Kidney disorder. Yes. Renal glycosuria, diabetes mellitus. I have been telling it again and again. If you people are not understanding, at least tell me that I am not understanding, or else I am having difficulties in understanding over this part. I'll repeat it. I'm asking again and again during my class that if people are not understanding, ask me. I know that in first class it is difficult to understand. That is why I ask, if people are not understanding, just tell me. Don't be silent over there that the sir will come, take class and we will go home and that's all. You came here to learn, so learn it first. Sit down, everyone sit down. What are the causes of hematuria? Can anybody tell? You can tell. Stand up.
RBCs released in the
Urine. So what are the conditions where it can be there RBCs in the urine? RBC eruption नहीं होता. In case of stones, renal stones can be the cause, cancer can be the cause, it can be bladder cancer, it can be kidney cancer, it can be stricture, it can be TB, tuberculosis of the bladder. In any pathology, whenever it is involving the kidney, ureter, urethra or bladder, the whole urinary system, whenever there is any pathology, the mucous membrane which is there inside, that can peel off from there. Like the way skin peels off, the same way the mucous membrane can peel off and little bit of RBCs can come out, and that will cause the hematuria. Whenever there is a stone disease, do you think why stone disease will cause hematuria? Why stone will cause hematuria? Yeah, the edges are not regular, the edges are not smooth, it's not like a ball, there are irregular edges, and whenever the stone is coming out, it will cause micro damages, micro tears inside the lumen. So whenever it is causing micro tears, these will lead for those RBCs to come in the urine sample, and ultimately it will come in the urine sample. Getting it? Try to understand it. Sit down. So, what are the common causes of oliguria? Again, back to the dehydration. Dehydration is a cause of oliguria because the water is already getting out because of, it can be because of diarrhea. It can be because of severe, you have been exposed to sun for a long time. Because of that, you have been sweating profusely. Vomiting, exactly. These are the causes of oliguria. You are undergoing dehydration, but for what reason you are getting dehydration? Dehydration is a broad term. There are multiple examples of giving. So that's how you have to correlate. Don't just mug up things like oliguria पढ़ लिया, oliguria में 500 से कम होगा तो फिर oliguria. Polyuria पढ़ लिया, polyuria में 2500 से. Why? Why is it important? That is you have to know. So give me two causes of polyuria. Pardon?
High water intake.
High water intake, exactly. High water intake can also lead to polyuria. Let's say you are taking 5 liters of water today. Now you will urinate also 4 liters. So is it polyuria? Is it a disease? No. It is because you have taken more amount of water. That is why water is coming out in your urine. That is a physiology. But it's a polyuria because the amount is more than 2.5 liters. Fine. Now, one more condition like diabetes insipidus. It is because of the misbalance of the hormone, that is antidiuretic hormone. Because of the defect in the hormone, the water is not getting reabsorbed by the kidney, water is losing. And that is why you are getting the polyuria as well. Okay? Now, glycosuria already done, hematuria done. Now, why 8 drops of urine sample is used in? Exactly. So, what are the byproducts? You tell. 3 names that I have mentioned. There are more substances like that. Say one name. Why DM patient develop polyphagia and polyuria? Polyuria. That is the reason for polyuria. Polyphagia. What is polyphagia? Yes, increase amount of hunger. The patient wants more and more amount of food. Why polyphagia? Why polyphagia? Polyuria, he already told. I have already mentioned polyuria. Why polyuria? Why polyphagia? And there is one more condition that can be. Polydipsia. Exactly. What is polydipsia? Increased thirst. So increased thirst, increased urge to intake food, and increased amount of urine excretion. These are the three trio that the patient can come with in case of a diabetes mellitus. These are the prime symptoms that the patient will come with. Okay. Now why there will be polyphagia? Can anybody tell? Yeah, say.
When more sugar is coming in, so there are like lack of carbohydrate or sugar in them too.
Yeah, 90% true. There is one line that you have to add is, there is in diabetes mellitus what happens? There is a defect in insulin. Either the insulin production is less or else the insulin is not working properly. Because of that insulin resistance, the glucose is not getting metabolized. When the glucose is not getting metabolized, glucose is excreting out in urine. And if the glucose is not getting metabolized, then from where we will get the energy? We will not get the energy. For that energy crisis, we feel like eating more and more. Understood? You are correct. But there should be one adding, that is the insulin resistance can be there, or the insulin is very low in the body. Because of that, these things are happening. Okay. Now, which drug causes orange color urine? Now, if only rifampicin. Isoniazid causes what? Isoniazid gives only false positive results. Rifampicin only gives the orange color urine. And which disease gives mousy smell of urine? Phenylketonuria. Exactly. Phenylketonuria gives the mousy smell of urine. What is isosthenuria? Now this one was not taught in your classes, I know that, but just for your knowledge. What is isosthenuria? Anybody has any idea? Which book are you people following for practicals? You people are not following any practical books. Why? Theory books? Which book are you following? Vasudevan. So Vasudevan also has a practical book as well. Who is following Satyanarayan? Who is following Vasudevan? Vasudevan. Vasudevan also has a practical book. You can follow that as well. You can follow Ashish Sharma, Anita Sharma. At least follow some practical books so that you have a basic idea of it. Make a habit of reading books. Probably it can be for 1 pages only. Today you have read only 1 page, and reading 1 page doesn't make much of an effort. So make a habit of reading. No, come to the point. What is isosthenuria? What is isosthenuria? Again, try to break the word. What is iso? What is hypo? What is hyper? Hypo means? Hypo means less. Hyper means? Iso means? Iso means equivalent. Equivalent. Now, what is isosthenuria? Same. Same what? Same what? What can be more? What can be less? Solutes and the water contents. What do we say it? Specific gravity. If the specific gravity is fixed to a particular value, what is the particular value? The particular value is? No. The value is 1.010. If it is the same exact value, then it is called as isosthenuria. If the specific gravity of an urine sample that you have collected from a patient and the specific gravity is this much, exactly this much, whatever the condition is, it will come this much, then it is isosthenuria. And there is only one condition that can give you isosthenuria. What is that? Chronic renal failure. Chronic kidney failure or chronic renal failure. Chronic renal failure. Okay, that is one condition which can give you isosthenuria. Okay, so these are some extra questions that can be asked. Now, one more thing. Who else have understood this measuring the specific gravity? Who knows to measure the specific gravity? This has been taught to you by ma'am. Solve this question. 0.001. Yeah. Why? Why you are adding this? Tell me this first. Don't add something which you are not understanding. Okay? Why did you write this? This is the specific gravity. What? Which specific gravity? That is already measured. So you should write this much. Yeah, fine. Now tell them why you did this part. What is the explanation? Yeah, tell them.
So that's like the standard temperature, because if we go to different region, the
Exactly.
temperature can be different. So
Yeah.
we take a standard temperature.
Hmm.
The temperature is given.
Given temperature.
And the specificity is given here.
Huh.
And
This much?
is the increase
This much is the change for each
each 3
3-degree change. That is why you are first measuring the, see over here, the room temperature is given 38 degree. Fine. We have to measure in 20 degree centigrade. And for each 3-degree change, the specific gravity will change by this much, 0.001. That is why she did what? She measured the temperature difference. Then divided it with 3. And jitna aayega, with that she multiplied with this much. Then the value she got and added with the base value that you got already. Right? Solve it. How much it comes? See. Solve it. It's fine. Don't be afraid of maths. If you have solved this much, see how much it comes. 18 by 3 into 0.001 plus 1.020. Right? This is 6. 6 into 0.001 plus 1.020. How much it comes? 0.006. Please bear with my handwriting. It's too bad. Okay. How much it comes? 1.026. So this is the corrected value. Fine. So this much is important. If you make it, then the rest of the things are class 1 mathematics. You divide it, minus it, divide it, multiply it, then plus it. Khatam. Fine, go. Next, somebody else come. Someone else. Now you people know how to do it, right? Some volunteer, somebody come. Let's see who wants to do it. No volunteer. Somebody volunteer. Someone. Yeah, I'll repeat it again. Anyone volunteer? No one? Then I have to choose randomly. You come. Now, the condition is the temperature is not 38 degree. The temperature is 11 degree. In 11 degree, you got this much value. Now you measure. Not another 0, 0, 0, 1. Yeah. Big round of applause for him. He has solved it. Now, you were asking, you did not understand, right? Yeah, tell me which part you did not understand. The formula. First of all, see, when we are measuring the specific gravity, let's say we are in Kashmir. Okay, the temperature is not 20 over there. Or let's say we are in Kerala. The temperature is more than 40 over here. Okay, we cannot make the temperature to a particular degree of Celsius in everywhere, all over the India or all over the world. We cannot do it. So we have to come to a common temperature. That is where we are measuring everywhere, or else we are grading it with or equalizing with all over the world, all over the India. Okay. So for that reason, we take the medium temperature as a 20 degree. That is fixed everywhere. So that is why we compare. Like you take a sample in here, you measure it over here, and you take a sample in Pune. The temperature is different in both the places. So you cannot change the weather completely. You can change your inside the lab's environment, but not the all over the area. So that is why we take the temperature as 20 degree. That is the base temperature. Okay. Everything that have to be measured is at 20 degrees centigrade. Okay, got it? This much, that is the base temperature, that's where you have to measure the specific gravity. But in what temperature did you measure? You measured the temperature at 38 degrees centigrade. Fine, you have measured it with 38 degrees centigrade, so the value that you are getting, that is not right. That have to be calibrated at 20 degrees centigrade. Right? So how will you calibrate it? So the fixed formula is, for every 3 degree rise in temperature, you have to add this much value. This is again fixed. This is tried and tested. For every 3 degree rise in temperature, you have to add 0.001 with the value that you are getting. Let's say the temperature is 20 degree, it should be, but the temperature that you have measured is 23 degree. Then the value would be what? This much plus only this much. Gets what? 1.021 at 23 degrees centigrade. Getting it? So if it is, instead of 23, if it is 38, then what? If it is 38, then what? Then the difference is how much? 18 degree. Right? 38 minus 20 is how much? 18. 18 divided by 3 is how much? For each 3 degree you have to add this much. Remember this part. Fine. So 18 divided by 3 is how much? 6. Into 0.001 that you have to add. Fine. That comes 0.006. Fine. So this much value you have to add with the value that you already got. Then you will get the corrected ones. But what was his question was, it was in 11 degrees centigrade. In 11 degrees centigrade we are reducing the temperature. The temperature, environmental temperature is less. Now you cannot add with it. Now you have to minus from it. Got it? So if you minus from it, then this becomes like this. Anybody has any doubt? Can ask. No doubt? Okay. Now the last question. What will happen to the specific gravity in hypoosmolar and hyperosmolar condition? Now someone tell me what is osmolarity. What is hypoosmolar or what is hyperosmolar? It is in class 12, right? 11, 12, osmolarity. What is hypoosmolar, what is hyperosmolar? Some basic idea, I am not asking the book's definition. Tell me the basic idea, what is hypo and what is hyperosmolar? Exactly. So if it is hypoosmolar, then the solutes are less. And if it is hyperosmolar, then the solutes are more. So if it is a hypoosmolar, then what will happen to the specific gravity? It will be less. And if it is hyperosmolar, it will be more. As simple as it is. So anybody has any doubt about specific gravity? What is specific gravity? Any doubt? Right, fine. The orientation you got it, what is specific gravity? Now the bookish definition, that is of specific gravity. If you take a urine sample and you take a distilled water, the solutes that is present in the urine sample as compared to distilled water, that is the definition of a specific gravity. Now how much solute is there? In simple word, for our understanding, we say if the particles, the more amount of particles are there, the more will be the specific gravity. The less the particles are there, the lesser will be the specific gravity. Now for an example, in a diabetes insipidus patient, the volume is more, urine volume is more, but the particulates are less as compared to the urine volume. The particles are normal, but the volume is so much. Let's say in a normal patient, there is 100 ml of urine. Okay, and the particle is 30. Okay, and another patient who is of diabetic insipidus, the volume is 200. Over there also the particle is 30. The particle proportion is normal, but the insipidus patient who is having more amount of volume, because of that, in comparison to this much, this 30 is half. This is compared to 15. Right? So that is why this becomes hypoosmolar, or the specific gravity decreases in case of diabetes insipidus. Now in case of diabetes mellitus, why is it increasing? Tell me, someone. Let's see how much you can correlate. Particles increase. Which particles? Like example?
sugar.
Exactly. Let's say a normal patient who is having 100 ml, who is having 30 particles. These are just an example, random example. Another patient of diabetes mellitus who is also losing 100 ml of fluid, and among that 30 are normal and rest of the 20 are sugars. Because of that, this extra particles, the specific gravity increases. In case of renal pathology is also the same thing. The kidney is not absorbing the other constituents of the urine. That is like protein is also not getting absorbed. Let's say in nephropathy. In kidney disease, what happens? It is not reabsorbing the sugar, not reabsorbing the protein as well. And then ultimately leading to diabetic nephropathy. In diabetic nephropathy, this can also happen. There will be hyperosmolar condition or the specific gravity will be more. So in a simple word, if the constituents that is present in the urine, if it is more, the specific gravity will increase. If the constituents are less, the specific gravity will decrease. Anybody has any doubt? Right? Okay. From the whole class, anybody has any doubts? The whole slide presentation, anybody wants to recall anything? Anybody has any queries? Please.
If a person has eaten sugar in the morning, so will it be counted as glycosuria?
Pardon?
If a person has eaten chocolates in the morning, will it be counted as glycosuria?
It will be glycosuria, but it is not a disease. Glycosuria, just break the word. What is glycosuria? Means presence of glucose or any glucose product, any reducing sugar in the urine. That is glycosuria. Not necessarily that it have to be a disease. Got my point? It's not necessary that it have to be a disease. If you are taking more amount of sugar will be also present in your urine, because kidney will not reabsorb everything. Up to a certain limit only it will reabsorb. After that it will excrete. Okay, that will be there. So it is glycosuria but not a disease. It's a physiological condition because of the diet. Anybody has any more doubts? Anything else? I'm going through the last slides again. If you see anything, if you don't understand anything, ask. Because in my next class, I'll again ask you questions. And that time, if people are not answering to my questions, I'll throw you out of the class. Telling you beforehand. So, understand the topic, then go home, repeat, read it. It will get inside your head. Otherwise, it won't. If you just keep on stacking up things one after another, before your this partcom or whatever this test we will take, that time you will be feeling like you are in middle of an ocean. You won't be able to finish it. So read whatever is being taught in your class on that very same day. If not everything, at least something. Get something in your head. Any doubts from here? This slide? See again. Fine? Everybody is fine with it? Please raise your hand and say, yeah, fine. Everyone is fine with these slides? Over here, any doubts?
Renal threshold for glucose.
Renal threshold for glucose. That I mentioned. What is renal threshold? The kidney is not being able to absorb as much as glucose it was absorbing properly or previously. Let's say normal kidney can absorb 70. And just giving an example. Let's say normal kidney can absorb 70 blood sugar from the circulating blood. Right? Now the kidney's threshold is less. Means now the kidney is absorbing only 30. Rest of the 40 it is not absorbing. So rest of the 40 is going where? In the urine. So that is the renal threshold is getting less. That is getting reduced. So that it is not getting reabsorbed again. Fine? Anything? This one is nothing over there. Nothing. This one. Procedure is also easy. 8 drops. 8 drops. What are the products? And another one I mentioned with my mouth. I did not write it. Homogentasic acid. HGA. Homogentasic acid. Composition. Anybody has any doubts from here?